Hello everyone. Good afternoon and a warm welcome to our KIMS Cuddles online neonatal education video. In this webinar, we will see about the most important intervention which is done for the neonates in the NICU day in and day out in level 3 NICUs and level 4 NICUs. That is the total parenteral nutrition, the components of the TPN as well as the preparation and the various complications. No. So the objectives of this webinar are, we will see the indications of the TPN, the various components of the total parenteral nutrition like proteins, glucose, lipids, electrolytes, calcium, phosphorus, and trace elements, and the preparation of the TPN, and the monitoring after connecting the TPN to the baby, as well as the complications related to the TPN. So the total parenteral nutrition is the most important intervention which is done in the initial days of any preterm or very low birth weight baby, as well as a sick term baby who is a post-surgery or post-cardiac baby in the NICU. The TPN is given to the baby until the baby is on sufficient enteral nutrition. So why prematurity and suboptimal nutrition? What are the disadvantages? So improper nutrition in a preterm baby can prolong the need for ventilatory support, as well as it can lead to the metabolic bone disease of prematurity, lead to anemia, and in the long run, it may lead to developmental delay, cerebral palsy, autism, as well as various cardiovascular and metabolic diseases. The preterms who are receiving inadequate nutrition are also vulnerable to different kinds of infections, as well as bronchopulmonary dysplasia, retinopathy of prematurity. They are also prone for poor head growth, decreased brain volume, and insufficient growth of various organs like heart, liver, and brain, thereby highlighting the importance of optimal and effective nutrition as soon as they are born, and highlighting the importance of the total parenteral nutrition until they are established on sufficient enteral feeds. So why total parenteral nutrition should be given for preterms? Let's see further. Early and effective nutrition in preterm as well as sick neonates is dependent mainly on early aggressive total parenteral nutrition. So the aim of total parenteral nutrition is to achieve the growth rates which are equal to the intrauterine growth rate of the baby. And the TPN also minimizes the nutrient losses of the baby and improves the growth. TPN also leads to proper neurodevelopment, which is measured in terms of Bailey scores as well as the brain growth. So TPN is given generally in preterm babies with immaturity of the gut, as well as in babies with surgical conditions who are unable to tolerate enteral feeds. So let's see the indications for total parenteral nutrition. As per NICE 2020 guidelines, total parenteral nutrition should be initiated for any preterm baby who is born less than 31 weeks of gestation, and also for babies who are born after 31 weeks of gestation, if sufficient progress in enteral feeding is not made in the first 72 hours of life. So any baby less than 31 weeks and in a baby more than 31 weeks in whom sufficient enteral feeding progress is not expected in the first 72 hours of life, TPN should be initiated. As well as in preterms and term babies with congenital gut disorders like gastroschisis, any intestinal obstruction, malrotation, any surgical conditions, necrotizing enterocolitis, post-abdominal surgeries, and critical illness like sepsis, post-cardiac surgeries, congenital diaphragmatic hernia surgeries, in whom we don't reach full feeds within the next 72 hours, we should initiate TPN for those babies. As well as TPN should be given for any baby who was already on some enteral feeds and then later it was stopped for some reason, like baby developing any NEC and you are keeping the baby NPO for the same. At that time, we should initiate the TPN again. And for preterms who are unlikely to be restarted feeds in the next 48 hours of life. For term babies, if you are unlikely to restart the feeds in the next 72 hours of life, then TPN should be started. These are also according to the NICE 2020 guidelines. So the guidelines according to our Indian AIMS protocol are any preterm baby less than 28 weeks of gestation with weight less than 1000 grams on day 1 of life, and any baby with between 28 to 32 weeks of gestation and born between 1000 to 1500 grams who is not expected to be on significant feeds for 3 days, as well as a baby who is more than 32 weeks and more than 1500 grams who is not expected to be on significant enteral feeds for the next 5 days. So you can follow any of these two guidelines, either NICE 2020 guidelines or our Indian guidelines for initiating the total parenteral nutrition. Now coming to the time of initiation of total parenteral nutrition, ideally it should be begun as soon as possible after the birth of a preterm baby or maximum within the first 8 hours of life. I will tell you the reason why it is so, and preferably it should be started through the central venous axis only, either the umbilical venous line or through a peripherally inserted catheter. Peripheral venous access, the normal peripheral access can be used only if there is a delay in placing the PICC line or an umbilical venous line, or it is for a short-term use when central venous catheter cannot be placed. In those conditions only, it is given through the peripheral venous access. Otherwise, generally TPN is given either through the UVC or the peripherally inserted central catheter. So what are the components of TPN? The first one is protein. So as I've already mentioned, the TPN helps in minimizing the protein losses and help in preserving the existing stores of the baby. Extreme preterm baby loses around 1.5 grams per kg per day of protein, as well as compared to a term baby who loses 0.7 gram per kg per day of protein if it is not supplemented either through feed or through parenteral nutrition. The intrauterine fetal protein accretion rate of a preterm baby is 2% every day. So suppose if you don't give any protein to the baby in the first initial 3 days of life, so that accounts to the absence of the fetal protein accretion 2% of every day, that is equal to 6%, as well as additional losses of 1.5 grams per kg per day. Total amounting to 10% of protein deficit. That is, if protein is not given in the first 3 days of life, a preterm baby will lose 10% of the protein from the body. So that leads to poor weight gain as well as the complications which we have mentioned previously. So one more thing is early amino acid intake improves the nitrogen balance as well as decreases the episodes of hyperglycemia. So how much we begin protein? In the initial first day of life, we can begin with 2 to 3 grams per kg per day as soon as possible. And it can be increased gradually and can be increased up to 3.5 to 4 grams per kg per day for preterms and 2.5 to 3 grams per kg per day for term neonates. So the calorie supplementation should be 30 to 40 kilocalories per every 1 gram of amino acid is recommended to optimize the protein accretion. Some semi-essential and non-essential amino acids like glutamine, tyrosine, and cysteine are deficient in TPN because of lack of stability. Remaining all amino acids are added in the total parenteral nutrition. So these are the essential amino acids, which are histidine, isoleucine, leucine, lysine, methionine, phenylalanine, threonine, tryptophan, and valine. These are all present in the total parenteral nutrition as well as the remaining semi-essential and non-essential amino acids. So that is about the protein in TPN. Next, coming to energy. Energy is given by both carbohydrates, that is glucose, as well as the lipids. In the initial days of life, a preterm baby's energy expenditure is roughly around 30 to 75 kilocalories per kg per day. So if we have to supplement at least 60 to 70 kilocalories per kg per day for positive energy balance. A positive energy balance of 20 to 25 kilocalories per kg per day in a preterm baby helps in achieving optimal growth for the baby. Always we should try to maintain euglycemia. We should avoid hypoglycemia, which is less than 40 milligrams per deciliter of blood glucose, which may lead to the occipital brain injury as well as developmental delay and other complications, as well as we to try to avoid the hyperglycemia, which is defined as more than 145 milligrams per deciliter of blood sugar, which leads to hyperosmolarity as well as increased diuresis in the baby, which may lead to dehydration. And there is also a risk of intracranial hemorrhage if untreated. So whenever we give dextrose as an infusion, so the endogenous hepatic glucose production is not suppressed in a extremely low birth weight baby despite insulin and parenteral glucose. This leads to hyperglycemia. So we should always strictly monitor the blood glucose levels of the baby, and the initial target GAR for the babies in the initial few days should be between 4 to 8 milligrams per kg per minute. We should try not to exceed more than 12 milligrams per kg per minute at any time, which can lead to hyperglycemia. So whenever a hyperglycemia is noted, we tend to start insulin infusion. According to 2011 Cochrane review, insulin infusion, regular insulin infusion in a preterm baby is associated with a risk of increased mortality, which was observed at 28 days of life. So regular insulin infusion should be avoided. We should titrate the blood glucose strictly based on our GAR only. Then one more thing, if we give excessive glucose, more than the glucose oxidative capacity of the baby, leads to the lipid synthesis, which is an energy expensive procedure for the baby, which increases the basal metabolic rate and also promotes the cholestasis. That's why excessive glucose should also be avoided. Next, the third important component in TPN is lipids. Lipids are composed of triglycerides, phospholipids added for emulsification, and glycerol added for isotonicity. These are the three main components of lipids in the TPN. So there are three generations of lipid emulsions. The first generation is soya bean or safflower based emulsion, which example is intralipid, which contains more of long chain triglycerides as well as omega-6 omega-6 more, which leads to increased cholestasis and risk of sepsis, which I will explain later. The second generation, 50% medium chain triglycerides are added. So the examples are lipofundia and clinolic. These preparations are currently not available. We are using currently the third generation lipids, which have more of omega-3 immunomodulatory effect, which is the example is the SMOF lipid. We are using 20% SMOF lipid composed of soya bean, medium chain triglycerides, olive oil, and fish oil. The other examples are omega-1, which contains only 100% fish oil, as well as lipoplus, which contains MCT, soya bean oil, and fish oil. These are better tolerated by the babies and leads to decreased incidence of parenteral nutrition associated liver disease. Fish oil based emulsions reduce the risk of cholestasis. They reduce the oxidative stress for the baby, and they provide the docosahexaenoic acid, which assists in the brain growth and retinal growth. And fish oil based emulsions have anti-inflammatory effects and have ideal ratio of omega-6 to omega-3 polyunsaturated fatty acids, which helps in prevention of cholestasis, and they also have increased vitamin E, that is alpha tocopherol. Less omega-6 polyunsaturated fatty acid leads to decrease in the risk of essential fatty acid deficiency. So lipids which are supplemented at least at the range of 1 gram per kg per day in the initial few days helps in avoiding the essential fatty acid deficiency in the preterm babies. So we are using lipids in a combination of the third generation lipids, which is the 20% SMOF lipid. So no lipid supplementation in the first 3 days of life leads to essential fatty acid deficiency. So lipid should be begun within the first day of life itself. Early IV lipid improves the growth in ELBW infants and also improves the nitrogen balance. So we have to start the lipid at 2 gram per kg per day and on day 1, and it can be increased up to 3 to 4 grams per kg per day. So whenever the baby is on any lipid infusion, it is ideal to monitor the triglyceride levels. So maintain the triglycerides always within the range of 150 to 200 milligrams per deciliter. 20% SMOF lipid is better tolerated than 10% SMOF lipid because it contains lower phospholipid, which interferes with the triglyceride clearance, and hence it leads to less hypercholesterolemia. So one disadvantage of lipids is if it is exposed to direct light, the lipids may form toxic peroxides. So that's why we should always cover the lipid infusion and the tubing with an aluminum foil. So we have completed the first three components of TPN. Now let's see the comparison of different components in the breast milk as well as the different lipids. Mainly we will highlight on the SMOF lipid. So in the breast milk, this is the gray one is the saturated fatty acids. The blue line is the monounsaturated fatty acids. The yellow one is the linoleic acid, as well as the green alpha linoleic acid, followed by arachidonic acid, EPA, and docosahexaenoic acid, eicosapentaenoic acid, and docosahexaenoic acid. You can see the composition in the breast milk. So now if you see the different types of lipids like intralipid, nutrilipid, clinolipid, they are not matching with the maternal breast milk lipid composition. So if you see the SMOF lipid, it is almost nearer to the saturated fatty acids, monounsaturated, and linoleic acid. Everything is almost similar to the breast milk composition. So that is also one of the reason we are using the third generation SMOF lipid. Next, coming to the electrolytes. So electrolytes are generally not added in the TPN in the first 2 days of life due to expected extracellular fluid contraction and free water diuresis. So sodium is generally added from the 3rd day of life in a dose of 3 to 5 milliequivalents per kg per day. And it can be increased up to 7 milliequivalents in very low birth weight babies, because these babies are prone to develop hyponatremia due to renal immaturity and renal losses of sodium. So that can be decided based upon the weekly monitoring of the electrolyte levels. Next, potassium should not be added in the first 2 days of life. Only after establishing the adequate renal function and establishing the urine output, potassium should be added in a maintenance dose of 2 to 3 milliequivalents per kg per day. Next, calcium and phosphorus. In growing premature infants, calcium is added in a dose of 65 to 100 mg per kg per day, and phosphorus is added in a dose of 50 to 80 mg per kg per day. In our unit, we are adding K-phos, which is potassium plus phosphorus, in order to maintain the calcium-phosphorus ratio of 1.7:1 by weight and to avoid the metabolic bone disease of prematurity. Magnesium is also supplemented in the TPN. Magnesium is supplemented in the dose of 3 to 7.2 milligrams per kg per day. Next, coming to the vitamins. So this is the general dosage range of the vitamins. These are added in the MVI preparation. We are adding 1.5 ml per kg per day of MVI in the TPN. So vitamin A dose is 700 to 1500 IU per kg per day. Vitamin D 200 to 1000 or 80 to 400 IU per kg per day. Vitamin E 2.8 to 3.5 mg per kg per day. Vitamin K we are not generally adding, we are giving at the time of birth. Then vitamin C 15 to 25 milligrams per kg per day. Thiamine, riboflavin, pyridoxine, niacin, B12, pantothenic acid, biotin, and folic acid. These are present in the appropriate quantities in the MVI vial. So this is the daily nutrient intake requirement of the babies. So in the day 0, if you see, ideally we should give 40 to 50 calories, which increases to 70 to 80, and when the baby is growing preterm, it increases up to 100 to 125 kilocalories per kg per day. Protein we begin as 2 to 3 grams per kg per day, and then it is gradually increased up to 3.5 to 4 grams per kg per day. Glucose, if you see as a GIR, we give as 4 to 6 as mg per kg per minute in the first day of life, which can be increased if needed up to 12 mg per kg per minute. Fats are given as 2 grams per kg per day in the initial days and increased to 3 to 4 grams per kg per day. Sodium, potassium, and chloride are not added in the first 2 days, then later on added in the maintenance doses as described previously. Calcium, when baby is growing preterm, 65 to 100 mg per kg per day, and phosphorus 50 to 80 mg per kg per day. Magnesium, as mentioned, 3 to 7.2 mg per kg per day. This is the recommendation for the individual components to be added in the total parenteral nutrition. This is the comparison of the NICE guidelines as well as the SPEN guidelines. So generally we are following the SPEN guidelines. In the previous slide, the one I have mentioned is the SPEN guidelines. So you can compare both and follow any one of the guidelines which is suitable for your unit. So as per SPEN guidelines, proteins of maximum of 3.5 to 4, lipids should not exceed 4 grams, and then sodium, glucose, calcium, phosphorus, magnesium as mentioned. So the non-nitrogen energy to amino acid ratio as per NICE guidelines is 20 to 30 kilocalories of non-nitrogen energy per gram of amino acid should be provided for optimal weight gain. And as per SPEN guidelines, 30 to 40 kilocalories. In this, the calories requirement they have given more. 30 to 40 kilocalories per gram of amino acid should be added. So when the baby is on prolonged total parenteral nutrition, like when the baby is not expected to be started on feeds more than 2 weeks also, then the trace elements are added. The trace elements are chromium, copper, iron, iodine, manganese, molybdenum, selenium, and zinc. These are added in the doses mentioned here. Like copper 40 micrograms per kg per day in preterms, and for term babies 20 micrograms per kg per day. Similarly for iron, iodine, manganese, and molybdenum, these all can be added as a trace element solution is readily available. If you add it in the dose of 0.2 ml per kg, you can meet all the requirements of the trace elements needed for the baby. So this is the sample total parenteral nutrition notes for a 1 kg baby. Suppose if you calculate the total volume for a day 3 of life, if you take it as 120 ml per kg per day, which will be 120 ml, we'll minus the drugs 10 ml. So the remaining volume 110 ml. So this we usually make here as 3 lines, but it can also be made as 2 lines also, in which line 1 and line 3 can be combined. So whenever we are preparing as 2 lines, so the dextrose and phosphorus is initially added, adding the calcium gluconate in the last, so as to avoid formation of the precipitates. So this is the sample TPN chart in which 10% amino is added at 3 grams per kg per day, which comes to 30 ml. Sodium is added in 3 milliequivalents per kg per day, which is 6 ml. K-phos is added in our unit, 2 milliequivalents per kg per day, as well as MgSO4. And then we will mention the rate per hour for 24 hours. And then line 2, 20% SMOF lipid, 2 grams per kg per day, that comes to 10 ml. MVI is added to the lipid line, and heparin also we are adding in the lipid line. So line 2 we are giving for 18 hours, followed by a break for 6 hours. Line 3, we are adding separately to titrate the GAR for babies who have a fluctuating blood glucose levels. Next, let's see what is the calorie protein ratio of the this chart. So that is calculated as non-protein calories energy, that is lipid plus dextrose divided by the protein in grams per kg per day. So for this baby we are giving 2 grams of lipid. Each gram of lipid provides 9 kilocalories, so that comes to 18 kilocalories per day. And the dextrose, 15% dextrose we are supplying, so 100 ml of 15% dextrose contains 15 grams of dextrose. So if we are giving 58 ml, that comes to around 8.7 grams of dextrose per day. Each gram of dextrose provides 3.5 kilocalories. So the total kilocalories for 8.7 grams comes to 30 kilocalories. So the calorie protein ratio is lipid plus dextrose divided by protein. 3 grams of protein, we take it as it is. So that comes to 16:1, which is slightly lesser than the expected energy recommendation. It should be more than 20 at least. Then the second one is calorie nitrogen ratio, which is calculated as the calories provided by the non-protein like carbohydrates and lipids divided by nitrogen. So how do you derive nitrogen? 6.25 grams of protein is equal to 1 gram of nitrogen. So we are giving 3 grams of protein for this baby. So that is equivalent to 0.48 grams of nitrogen per day. So now the calorie nitrogen ratio is calculated as non-protein calories by nitrogen, which is 48 by 0.48, that is equal to 100. So the normal ratio is 100 to 150 is to 1. So this is ideally given in as per this TPN calculation. So these are the sample TPN calculation as well as calorie protein and calorie nitrogen ratios. So if you keep on practicing, you can learn daily chart the TPN, then you will not make frequent mistakes. So coming to TPN preparation, let's see how we should prepare the TPN and in which units TPN should be prepared. TPN should be prepared with utmost sterile precautions in level 3 neonatal NICUs, and it should be done only under the laminar flow. Don't prepare TPN in a normal way. So TPN should always be done in a laminar flow unit only. So in units with trained nursing staff to take care of IV lines, the nursing staff also should be trained to handle the central lines as well as the IV lines in a sterile manner with aseptic non-touch technique. Then laminar flow should be present for maintaining the asepsis, and proper equipment should be there and it should be working and in order, and there should be laboratory support to monitor the sugar levels as well as electrolytes and calcium and phosphorus. So what are the things needed? We need some sterile sheets as well as surgical gowns and surgical gloves and different sizes of syringes, that is 50cc syringe, 20cc, 10cc syringes for loading the TPN, that is aminoven, glucose and all, as well as we need the 3-way stopcocks, and we need sterile, that is sterile dressing set which contains the for cleaning as well as artery forceps. And we should in advance prepare the TPN chart for the baby. What are the medications to be kept ready before preparing the TPN? So 10% aminoven, SMOF lipid, dextrose different concentrations up to 25%, as well as 3% NaCl, KCl or KPhos. KPhos is better to prevent the metabolic bone disease of prematurity, as well as 10% calcium gluconate, heparin, and vitamins 1.5 ml per kg per day, and trace elements 0.2 ml per kg per day. So prerequisites for the TPN preparation. So the aseptic precaution should be followed. First, the persons who are preparing the TPN should wash themselves by according to the standard hand hygiene recommendations, and they should wear the surgical gowns and don the surgical gloves. And always trained personnel should prepare the TPN, and there should be 2 persons, one person preparing the actual TPN and the other one assisting. In our unit, both the staff, one doctor and one nurse, both prepare the TPN in a sterile manner, and one more nurse will help in assisting in giving the things needed for the TPN. So total 3 persons will be there, 2 persons will be completely sterile, 1 person will be helping. And we should never compromise on the disposables. Suppose if you have opened a PMO line and you felt that it is not sterile, it has slightly gone out of the sterile field, then don't at all hesitate to take one more. So never compromise on disposables to avoid the central line associated bloodstream infections in these preterm babies. And don't reuse the TPN solutions. Prepare TPN for 24 hours only, maximum 48 hours you can prepare. Then you have to prepare fresh again, and there should not be any interruption of the venous line carrying the TPN. That means the line, the central line which is connected to the TPN should be dedicated for TPN only, and it should not be interrupted for giving IV antibiotics or any other medications. So there should be a dedicated line for preparing connecting the TPN, and use of bacterial filters. So let's see in detail about the laminar flow. Laminar flow is a device which provides a clean air to the working area. It provides a constant flow of air out of the working area so that any bacteria which are tentatively be introduced by the working personnel don't go into the laminar area, and it is always flowing out of the laminar area. The air flowing out from the hood suspends and removes the contaminants which are suspended in the air and introduced into the working area by the personnel, and it is always moving out of the field so that the air is kept sterile and free of contaminants and floating particles. So the laminar hood should be on 24 hours in a day. If it is turned off for any reason, it should be turned on for at least 30 minutes prior, and it should be thoroughly cleaned before reusing. There are two types of laminar airflow hoods. One is the horizontal airflow. The second one is the vertical airflow. Both should be functioning properly. And then the pre-filter removes the gross particulate contaminants. The HEPA filter, which is the high efficiency particulate air filter, removes the fine particulate matter. That means it removes the 99.97% of the particles that are more than 0.3 microns or larger. So how to clean the laminar flow area? First, wash your hands and wear sterile clothing and gloves. Always use lint-free clean room cloths. Use sterile cloth for cleaning, and the cleaning solution should be 70% isopropyl alcohol with 2% chlorhexidine with alcohol solution. So we are using 2% chlorhexidine with alcohol solution. Always start cleaning from the back and then move to the front clean in a horizontal manner. Wipe the entire span of the surface in a side-to-side fashion, and then go down and overlap each swipe by 20% of the area. Clean in a horizontal fashion and clean the entire surface. Don't try to attempt to clean the HEPA filter. It will damage the media. So then we should keep the laminar flow cabinet on, and then UV light also should be on for 30 minutes at least. UV light should be stopped just before you start preparing the TPN. Clean the laminar flow as mentioned above, and close the doors and keep it on. Later on, when you are starting to prepare the TPN, you can open the door. Check the expiry dates of all medications which you are going to use. Chart the TPN and keep it ready. And now the two personnel who has washed their hands, wore sterile gowns and gloves, will start preparing the TPN. Prepare TPN just before connecting to the patient. So to avoid any other person handling and risk of contamination. So whenever you are going to connect the TPN to the baby, just before connecting, you prepare the TPN and freshly connect to the baby. You can prepare for 24 hours, maximum of 48 hours. The working area is 6 inches from the air filter. Always the person who is preparing the TPN should keep his or her hands inside the cleaned area of the hood as much as possible. You should not keep your hands outside, and prepare TPN under the laminar flow only. Do not forget and touch your hair, face or clothing while preparing the TPN. While drawing the medications, the hand should never obstruct the airflow around the area where the needle enters the vial or the ampoule. While withdrawing, the finger should not come in contact with any part of the needle except the flat part at the end. Mixing of TPN. First, add phosphate to the glucose solution. Swab all the tops of all the additive ingredients, that is the ampoules and the vials. This is done by the nurse who assists in sterile fashion with the doctor, and one more nurse will be providing her these materials to clean and keep aside. And then electrolytes are added to the amino acid solution, and it should be mixed well after each addition, and transfer the amino acids to the glucose containing bottle. If you are preparing the 2-line TPN, add calcium in the end. Avoid precipitation. Okay. Keep calcium and phosphate salts well separated so that the precipitation does not happen. And then the connected TPN should be taken in a sterile gauze, sterile cloth, and it should be connected to the patient by practicing the aseptic non-touch technique, that is scrub hub of the PICC line with 2% chlorhexidine for 15 seconds, and then wait for another 15 seconds and repeat the process 3 times. Then the doctor should connect the TPN to the PICC line or umbilical line. Avoid breaking the line for medications. Frequently check the PICC line entry site for redness. Now I will show you the sample TPN preparation video which is done in our unit. So this is the video of the total parental nutrition being prepared in our unit under laminar flow area. You can see this side the doctor wearing the surgical gown as well as cap and mask and surgical gloves after thorough hand washing. She is the nurse assisting the doctor, and she has taken the, just a minute, I'll go back, and she has taken the dressing set and opened it, and then she is taking the um, 2% chlorhexidine plus isopropyl alcohol, and then she'll be taking each one of the medications. This is the PMO line. She is keeping it and placing it in a sterile manner on the opposite side. It is the three-way stopcock, syringes, 50 cc, 10 cc, and 1 cc syringes. Now, the other helping nurse will be holding the medicine, which like aminoven. This will be cleaned by this nurse. And once she has cleaned that top part, she's cleaning the remaining part, and she's keeping all these medications like aminoven, dextrose, small lipid, electrolytes, and MVI, calcium, K-phos, everything she has kept here. She has broken all the vials. So now the doctor starts loading the TPN. In a sterile manner. So how much, suppose if we want to use 50 ml of aminoven for the baby, 50 ml was taken and it was discarded. And then all the components of the line 1 TPN are added one by one in the order that I have mentioned. Calcium is added to the last. So you can see that they are drawing the medication just in front of the laminar flow and inserting it straight into the aminoven bottle in a straight fashion, so that the laminar flow is not obstructed to the tip of the needle. So all the components of the line 1 TPN are now mixed, and there is no precipitate in the line 1. Now it is connected to the PMO line. And then it is attached to a three-way stopcock, and then it is removed of air, flushed from both the sides. And a 50 cc syringe is connected to the other end of the three-way stopcock, and one more PMO line will also be connected. And if you draw it into the 50 cc syringe and through the second PMO line, it can be connected to the baby. So this is the second lipid line preparation. Small lipid is collected. In that, MVI will be added in the recommended dose. MVI is being added to the lipid, and in our unit we are adding heparin also to the lipid line. So this is again connected to the PMO line. And then the TPN is taken in a sterile cloth, and it is folded and taken to the baby and connected to the baby following the aseptic non-touch technique and the cleaning methods which I have described. So now let's go back to the presentation. So hope everyone can hear me again. So in this way, total parental nutrition is prepared and connected in a sterile manner to the preterm baby to avoid the central line associated bloodstream infections. Let's continue the presentation. So after connecting TPN to the baby, how we will monitor? So the blood sugar should be done every 6 hourly to watch for hypo and hyperglycemia. Electrolytes, creatinine and urea should be done twice weekly. Calcium, phosphorus, magnesium, LFT and triglycerides are recommended to be done every weekly. Head circumference and length, anthropometry should be monitored every weekly. Weight, energy and protein intake should be calculated daily. Parallelly, you will begin enteral nutrition for the baby and hike in as per your unit protocol. So whenever the baby reaches 140 to 150 ml per kg per day for a less than 28 weeker baby, or 120 to 140 ml per kg per day for a baby who is more than 28 weeks, then you can consider stopping total parenteral nutrition. Always you should maintain the TPN monitoring charts. Now, after seeing this, let's see what are the complications related to total parenteral nutrition. There are many complications which are associated with TPN, which you should be watchful for. These can be divided into the following major categories: metabolic complications, catheter-related complications, mechanical complications, and parenteral nutrition-related complications. Among the metabolic complications, hypo and hyperglycemia is based on the GIR which you are giving, as well as metabolic acidosis, metabolic bone disease of prematurity, hyperlipidemia, cholestasis, trace mineral deficiencies are the commonly noted metabolic complications following TPN. Catheter-related complications are the major one is the central line associated bloodstream infection, which should be tried to avoid, followed by thrombosis. The mechanical complications are line occlusion, line leak, extravasation, dislodgement of the line, breakage, migration, pericardial and pleural effusion. This happens if the line is not in correct place. That happens to extravasation and leak, which can be observed as swelling, redness over the area, whether it is if you are placed in the upper limb over the clavicle, or in the abdomen if you are placed in the lower limb. Pericardial and pleural effusions are very rare complications of TPN if the line gets into the pericardial cavity. Parenteral nutrition related complications are related to the stability of the TPN, drug compatibility, peroxidation of lipids, which can be avoided by covering the lipid line with aluminum foil, as well as increase in the osmolarity. Always try to maintain osmolarity less than 900 milliosmoles per liter. Coming to the first, metabolic complications. Among the lipids, the complications are hypertriglyceridemia and hyperglycemia. With superadded sepsis, lipids may impair the insulin sensitivity and increase the gluconeogenesis. The glucose-related complications are hypo and hyperglycemia. Parenteral amino acids which are added to the TPN decrease the risk of hyperglycemia by stimulating the endogenous insulin production. Coming to the proteins, higher amino acid intake versus lower amino acid intake was compared in few studies. There was no effect on survival in preterm babies as well as the neurodevelopment, but higher amino acid intake leads to lower rates of growth failure, increased head growth, and fewer prematurity related eye problems, but not severe ROP. Increased levels of protein breakdown to products of urea, according to the Cochrane 2018 review, but it is a low quality evidence. Then the next one is parenteral nutrition related metabolic bone disease, which presents with symptoms and signs of decrease in bone mineral density, osteoporosis, pain, and fractures, which are reported with long-term parenteral nutrition. The cause of metabolic bone disease of prematurity is multifactorial, including mechanisms related to both the underlying disease process, the sickness level of the baby, as well as parenteral nutrition, that is excess of vitamin D, phosphorus, nitrogen, and amino acid intake, as well as energy imbalance and aluminum contamination. These are the common causes for metabolic bone disease following the total parenteral nutrition. The second complication is related to infection. How to prevent the catheter-related bloodstream infection? Use a PICC line or a tunneled CVC. These are the guidelines according to the SPEN 2018. Use a dedicated line for TPN. Use as minimal ports or lumens as possible. If you need only 2 lines, connect only two-way octopus. If you need 3 lines, connect 3-way. Don't keep the line ideal without connecting it to the baby. Silicone or polyurethane material is preferable material for infusing the TPN. UVC is placed for short-term vascular access less than 7 days. Prophylactic antibiotics like vancomycin does not reduce the catheter-related bloodstream infection. A Cochrane review found only 3 studies in neonates which suggested the vancomycin related antibiotic lock, which might decrease the infection risk by 18.5% without increasing the risk of hypoglycemia, but there was insufficient evidence to prove this. In the SPEN guidelines, routine use of heparin was not recommended, and routine use of inline filters are also not recommended for neonatal TPN. But in our unit, we are using heparin because of this trial, which is the randomized control trial of heparin in total parenteral nutrition to prevent sepsis associated with long lines. That is the Hilltop trial, which was published in Archives in 2010. So in this, the background is we know that heparin has been shown to prolong the effective duration of neonatal long lines and to reduce the ability of bacteria to adhere to foreign surfaces. What they studied was whether the regular infusion of heparin through the line reduces the catheter-related sepsis as the primary outcome. A randomized control trial which compared heparin which was infused at 0.5 international units per ml with no heparin in 210 infants shows statistically significant reduction in all episodes of culture positive sepsis in babies, and the number needed to treat was 9 with a confidence interval of 0.32 to 0.98. So that is why heparin is being added to the TPN. Continuing on infections, any fever or temperature change in a baby, fever or hypothermia in a baby, along with a change in the clinical or laboratory parameters should raise the suspicion of CLABSI until proven otherwise. Then paired blood culture should be sent, and the removal of the line which was in place at the time of developing infection for the baby should be done immediately. Antibiotics should be started covering both gram-positive and gram-negative organisms, and the duration of this treatment for this CLABSI infection is 10 to 14 days. So coming to the next complication related to the TPN, which is the occlusion. It can be either due to a thrombosis, which is diagnosed by ultrasound and treated with low molecular weight heparin generally, and non-thrombotic occlusion due to the material in the TPN itself, that is lipid and calcium phosphate precipitation. This can be prevented by adding in the proper order, and improper line position, like it is below the bone clavicle or it is near the shoulder, that also leads to the extravasation, which leads to local pain, swelling and redness. So always the tip of the line should be confirmed by the X-ray. So here, before going to the PNALD, always the dressing of the line, PICC line should be with a semi-permeable dressing, and the area should be always inspected every day for redness or any local site of infection, and the monitoring chart should be maintained. If you find any redness near the site of insertion, always preferable to remove that line. Next, coming to the parental nutrition associated liver disease. It's a heterogeneous liver injury characterized by cholestasis, steatosis, fibrosis, and cirrhosis. A persistent direct hyperbilirubinemia, typically more than 2 milligrams per deciliter, when it is present and with no other causes of liver disease, can be diagnosed as a PNALD in neonates who are receiving the prolonged parenteral nutrition. The diagnosis is by liver biopsy, which is a gold standard. The risk factors of PNALD are many, which can be divided as patient-related factors and parental nutrition-related factors. The patient-related factors are prematurity, surgical abdomen, different surgical conditions, infection, NEC, short bowel syndrome, CCHD, like cyanotic congenital heart disease and congenital diaphragmatic hernia, surgical conditions which necessitate the need for TPN for a long duration. All these factors are risk factors for PNALD. So this can be divided in this tabular form. Patient-related factors are prematurity, SGA, IUGR, any gastrointestinal disorder, lack of enteral feeds, NEC, gastrointestinal surgeries, function and anatomy, bowel length, presence of ileocecal valve, and any short bowel syndrome is high risk for developing PNALD, intestinal continuity, and infections. PN-related factors are prolonged duration of parenteral nutrition, central line associated bloodstream infection, presence of phytosterols in the lipid component, and the types of polyunsaturated fatty acids, presence of antioxidants, excess or deficiency of macro and micronutrients, as well as the different components like carbohydrates, amino acids, fat, and copper. So let's see the etiopathogenesis of PN-associated liver disease. So carbohydrate excess, amino acid imbalances, the deficiency of taurine, cysteine, or excess methionine. Cysteine improves the solubility of calcium and phosphate in the TPN. Any manganese excess, lipid emulsion components play the greatest role in the development of the PNALD. Among them, the soybean oil has been largely attributed for the development of PNALD due to the high phytosterol content as well as high concentration of omega-6 polyunsaturated fatty acids compared to omega-3 and low concentrations of antioxidants, that is alpha tocopherol. This is reversed in fish oil based emulsion, so we use a combination of both. Any sepsis also leads to increased production of lipopolysaccharides and cytokines, which alter the expression of specific bile acid transporters, thereby decreasing the bile flow and leading to the biliary sludge and cholestasis. So sepsis also increases the risk of PNALD. SMOF lipid decreases the inflammation and oxidant-related injury. So the PNALD is contributed by these factors. The soybean oil is made up of 43% cholesterol and 57% of phytosterols. Fish oils are made up of cholesterol only. These phytosterols, for example, sitosterol is one of the type of phytosterol. This interferes with the bile acid transport, leading to the biliary sludge. Sitosterol inhibits the cholesterol 7 alpha hydroxylates, the rate limiting step that converts the cholesterol into bile acids in the liver. So PNALD is influenced by the dose and composition of the intravenous fatty acid emulsion. The phytosterols contribute to the development of PNALD, which is contributed in addition with sepsis-related inflammation and altered omega-6 to omega-3 ratio, which leads to lipid accumulation and cholestasis and steatosis. So now we have come to the end of the complications related to the parenteral nutrition. So till now, what we have learned? We have learned that early provision of total parenteral nutrition, including amino acids, glucose and carbohydrates and multivitamins, calcium and phosphorus, is beneficial for the preterm babies in order to preserve their stores and prevent the early postnatal losses, as well as helps in improved weight gain, head growth, and prevention of the EUGR. So it's a life-saving intervention in preterm babies, provided strict asepsis is followed while preparing and connecting the TPN to the baby, and following the precautions like maintaining the proper charts, monitoring for line-related infections, monitoring the lab abnormalities like hyponatremia, hypo or hyperkalemia, hypo or hyperglycemia, frequently monitoring these according to the protocols which are provided and correcting the same, and monitoring for the line-related infections, as well as close monitoring for bloodstream infections by clinical condition of the baby, and acting as fast as possible by starting IV antibiotics and removing the lines, and always try to establish enteral feeding as early as possible for any preterm baby according to the guidelines, which we can take up in the coming classes, how to establish the feeding and increase the feeds for preterm babies helps in reducing the TPN related complications, and it can be used as a safe measure to prevent the mortality in the preterm VLBW as well as sick neonates. Thank you for patient listening.